Next, we will hear from Dr. Vincent Mor, the Florence Pierce Grant Professor of Community Health in the Brown University School of Public Health and Senior Health Scientist in the Health Services Research Service at the Providence Veterans Affairs Medical Center. He has extensive background researching and evaluating the impact of programs and policies in aging and long-term care. Dr. Mor will continue our conversation on nursing home preparedness and COVID outbreaks in long-term care facilities. We're so fortunate that he can be with us today to add his perspective and expertise to this conversation. Dr. Mor?
Thanks so much for this opportunity to present research my colleagues and I have been doing since last March when the pandemic first began to hit nursing homes in the United States. I'm so glad that Dr. Newman had provided all the background so I don't have to do all that background material, so it was really great, wonderful perspective, and allows me to put a more detailed perspective on how the pandemic has affected the nursing home world in the U.S. So I have lots of acknowledgments. I'm a researcher, so I have grants from the National Institute on Aging, and each of those large grants had a variety of different supplements that were made available to us as soon as the pandemic became obvious. And I have to thank all of my colleagues. I certainly didn't do any of this work alone. I couldn't have done any of it without them. Thank you. What I want to do is give you a background to the nursing home preparedness behind this, and then talk about the competing narratives regarding the cause of the outbreak and how people interpret that. Then the importance of having really good, timely data to basically diagnose the problem of who's at fault, as it were, and then prescribing solutions to ameliorate it so that we don't have the wrong solution addressing a problem that's unrelated. And then present you some study findings about that, and then I'll talk briefly about the most recent things we're doing as it applies to vaccination. So Americans' perceptions of nursing homes have always been quite poor, so because they've been shaped by periodic scandals that are local, national, the national news outlets. Nothing thrills a newspaper reporter more than being able to say something scandalous has occurred, and it wasn't in my family, so it was just a big problem. It's often seen as the fault of the facility, perhaps the industry that it's for profit, and also that there's governmental failures with respect to regulation. I personally have always found it very interesting that we periodically have physician scandals like, excessive opioid prescribing, but that in the mind of the public they don't tar all physicians. Yet nursing home scandals do seem to condemn all providers. And it's within that background that the first frame of the narrative began in the U.S. So the first deaths in nursing homes, actually from the first deaths from COVID altogether in the United States occurred that we could find was in Seattle at the Kirkland Nursing Home. There were a big shock. It was lots of people died very, very quickly, and there seemed to be some hiding of what was going on in that process. There was
Dr. Mor?
Yes.
Dr. Mor? This is Kate from NIHCM. Can I just ask that you speak up a little bit? It's hard for some of our audience members to hear you.
Okay.
That's much better.
I'm thinking through this. Okay, fine. In any case, so the notion was that the absence of infection control practices or the inadequate infection control practices were blamed on the facility, training, and understaffing, and that then was what was thought to be contributing to the high death rate and the fact that people were becoming infected at all, and inadequate supply and use of protective equipment. So the net result was that the newspapers and Medicare, CMS, reported that more deaths were occurring in low-quality homes, and so this was somehow or another all steeped in that sort of sense of quality. And if the interpretation and if the determination of what the problem is that it's poor quality, one would actually take a different approach in deciding how to do something about this. And yet the real issue was where these effects were occurring. So this was a classic piece where the New York Times called nursing home death pits is a part of a long article that was written last spring, and I remember having conversations with the authors, the reporters, and I found it not terribly helpful. And of course, this was the editors came up with the title, not the reporters. But the real issue here was trying to understand what were the determinants of becoming having an outbreak in a nursing home. And in an effort to answer that and many other questions, we established a relationship with a company, large nursing home company called Genesis Healthcare, that's located in Philadelphia, but has nursing homes throughout the country. We entered into a collaborative commitment. Brown's analytic prowess would actually help Genesis operations processes so we could be in constant exchange. So for the past literally 9 months, we've been meeting on a weekly basis with clinical leadership, their IT staff, and Brown investigators, trying to explore challenges that they're facing, trying to understand empirically what was going on. And by May, we'd already begun doing a lot of different analyses, and those were I'll be talking about right now. So the first thing was to try to find out, so what are the determinants of where an outbreak occurs? And we published that as a paper already, but we looked at the association of nursing facility characteristics and county prevalence of SARS with the probability that a facility had at least one resident with COVID. And the size of the facility, the number of beds in that facility was strongly related to the likelihood of a transmission. Percent of the residents who were African American had a very strong effect. And at the bottom of this slide, you'll see that the county prevalence, that is how prevalent the local community is about that, was the most important factor. And in fact, all of these other things are largely associated with the amount of traffic associated with people coming into the building who are living in an environment where there's high prevalence of the pandemic. And so with that in mind, and other colleagues of ours, it's now sort of accepted that the determinants of an outbreak was mostly community prevalence, that CMS and CDC now, actually their facility level data is now interpreted with this in mind. So in some sense, the data were helpful in shaping basically the agenda and the interpretation, which is a much more positive perspective than trying to sort of quote unquote blame the victim. And I was particularly conscious of that because a large nursing home that I work with a lot, it's a not-for-profit up in Boston, sort of a spectacular place, had been hit with many outbreaks, even though they have the highest staffing levels in the state and so on. And so it's really about the volume because it's a very large facility with people coming in from all over the community, and they live in, because they're underpaid staff, they live in the poorest parts of town, and it's the poorest parts of town in almost every part of the community, the country, that has actually been hit with this. Next slide here. So one of the other things that happened is that initially people were screening for SARS, for the virus, in the nursing home, as everywhere else, by looking at temperature. And geriatric patients historically have lower temperature, and yet CDC sort of set an average temperature threshold because whether you're in an airport or you're at a train station or you walk into a building and people are checking you, they're going to look for a single threshold. And it was 38.2 or something, 101. Genesis data had screening with temperature and other vital signs literally 2 or 3 times a day. So we looked at that and we said, hey, the threshold for when people their temperature rises relative to when they're tested positive seems to be at a much lower threshold. And we did this at both. So we did this both in the VA, which is the lower panel of these 2 slides, and then the upper panel. And on the upper panel in the upper corner, the upper left corner, is that's in the Genesis facilities, and the day 0 is the date people tested and tested positive, and you can see there's basically a rise started 3 days before, and that temperature, but it hit the day of testing was basically 37.2, so the threshold of people, what proportion of people hit that temperature threshold. And so that meant that the standard for what CDC's reporting out for what to look for in terms of screening for people with potential COVID had to be lower in the geriatric population. That's now part of their standard approach.
Dr. Mor, this is Kate again with NIHCM. We're just having still some sound issues on our end, so if you could just make sure you're holding the mic close to your mouth, that might help a little bit. It just seems to be cutting in and out a little bit. Thank you. Really appreciate it.
Is this better? Is this better?
Yes, that sounds clear.
Okay, great. So the asymptomatic transmission is complicated by, makes it very difficult to cohort symptomatic positive cases. Initially, we all thought that if you identified patients with symptoms, you put the patients who are symptomatic together, and you would try to isolate the people who were not feeling symptoms, presumably they were negative. And particularly early on, when there was fewer testing kits available, this was a real, this was the strategy that people were using to try to protect the people who were quote-unquote negative. But all of that ignored the fact that there's a lot of transmission from the people who were positive but asymptomatic. And so Genesis began doing these random sweeps where they tested everybody or most everybody in a building or wing, and that made it possible for us to identify the fact that there are very high proportions of patients who are asymptomatic even though they're positive. And here we see that something like, compared to 40% of the patients who are asymptomatic, who during facility-wide surveys, only 22% were symptomatic when they only tested people who were symptomatic in that process, meaning that it's really important to see that in terms of who was symptomatic. Next, we also saw that the proportion who were symptomatic was very strongly also related, asymptomatic, was very strongly related to the proportion of people who had COVID in the community, which is that top 5%. And I'm going to change my my device here. Can you hear me now better?
Yes, that is better.
Thank you. So I'm now holding the phone myself. Okay, so for the next slide, we wanted to look at mortality. What determines mortality? So in the community population, as Dr. Newman showed, mortality is the highest amongst the oldest age, but it's also very high amongst those with comorbid conditions. Now, the nursing home population is both old and sick and also very frail and functionally impaired. So there's a lot of question about whether or not, their immune systems were able to actually manage that and deal with that. But we still see lots of variation in the mortality rate, even amongst this very old, frail population in nursing homes. So we published this paper just recently. Where'd it go? There we are. In JAMA Internal Medicine, looking at the risk factors associated with 30-day mortality. And here's probably the most important take-home question, is we see 3 different panels predicting, what is the proportion of people dying at each level. So the panel A, you'll see that there's the highest mortality rate is associated with the absolutely oldest people. Panel B is the highest mortality rate is associated with those people who were most functionally impaired long before they acquired COVID. But cognitive impairment, with the highest level of cognitive impairment, was also very strongly associated with the likelihood of mortality. So it's age, physical function, and cognitive functioning, all 3 together, actually are probably far more important than any individual disease, making it so that that's one of the reasons the death rate is so much higher in the nursing home population, because they are that much sicker. We began to look at this issue of declines in mortality. And we've been looking at this, again, in the Genesis facilities. And here you see that the percent of the 30-day death rate, it's in the third column over, started at 26% in the period around March, dropped to 22, then 17, and now it's back down as of late September. It was back down to 11. That number has begun to, as Dr. Newman suggested, has begun to turn back up a little bit. But what's important here is this is a real trend that's associated with the level of infection out there, but also this is the mortality amongst the people who were positive. So it's not just because there was a reduction in the number of cases, the mortality rate per case was also dropping. And this is not attributable to what we sort of call a change in the mix of patients. Rather, this is attributable because we controlled for those factors. This is attributable to probably better wearing of the protective equipment, and could be that there was a shift in the genetic characteristics of the virus that was more prevalent last spring versus this fall. What is really going to be interesting is as we extend these data now into January, as we're continuing to do that. That's really, you have to watch that. And here we see the top line is for the people who are symptomatic, but even the people who are asymptomatic, they end up with at the time of diagnosis, they end up with a slightly higher mortality rate than the average mortality rate in a nursing home population. And again, that is also very similar to the community change in prevalence as it moves forward. So in summary, vaccinations are now well underway in the nursing homes. The early results suggest that about 80% of residents are accepting the vaccine, at least in Genesis. Virtually all of the facilities in Genesis have had their first clinic, their first opportunity. The complications are associated with if the patients test positive for COVID, they cannot be vaccinated, and that number of people testing positive for COVID, as Dr. Newman shown, has actually begun to rise, complicating the actual process of administering the vaccine as it goes in the nursing home settings. It is also the case that staff vaccination rates are a real challenge, and so far it looks to be about 50%, but really huge variation from one building to the other, with this sort of microculture of willingness to be vaccinated. And we're actually running a large pragmatic trial now trying to reduce vaccine hesitancy, increase vaccination rates even amongst residents, but also particularly amongst staff. And we're in the midst of doing that in about 140 facilities across the country. And we're very anxious to see how that works out, because this is a really important thing. And as the pandemic is spreading even more aggressively, with concerns about the more infectious variant coming from Britain to the States already here, also being of great concern. So I'm going to stop there and leave open for questions and for Dr. Kaplan to proceed. Thank you very much for your time.
Thank you so much, Dr. Mor, for providing us with another level of detail and understanding of how these facilities and individuals have been impacted, and showing us how data can be used to better understand the problem and identify solutions.